Hello, everyone. I am Jerry Vockley, and unfortunately, you won't be able to see me today. We've been having some technical difficulties, but they tell me you can see my slides. We're going to go ahead and get started. I am the director of the Center for Rare Disease Therapy at the Children's Hospital of Pittsburgh and professor of genetics and pediatrics at the University of Pittsburgh. And Chief of Genetic and Genomic Medicine for UPMC, and I welcome you to what will be our Rare Disease Day webinar. As you may know, in 2 days, we will have the rarest day of our calendar, February 29th, and that is Rare Disease Day. And we're having a number of activities across the campus here for that event, and this is one of them. I'm going to give you a talk that I've somewhat whimsically titled "The Alice Approach: Down the Rabbit Hole and Back Up Again." With a focus on a new era in therapies for rare diseases. So I hope you'll get something from this. For those of you who are online, I think there may be an opportunity to ask some questions at the end. I'm not 100% sure, but if you're watching this, it's going to be recorded, and you're watching it afterwards. If you have any questions, you can contact our director, coordinator for the Rare Disease Center, who you can find on our website. So my disclosures do a lot of research and some consulting. And start off with a question. Why should we study rare diseases? Why should we care? Well, it turns out that there are a surprising number of patients with rare diseases out there. Most people don't know that 3 to 5% of all infants are born with a genetic problem that brings them to medical attention. 0.5% of babies have a metabolic disorder that falls into our category of rare disease. 40% of infant and childhood mortality, a staggering number. And depending on how you count them, and whether or not we're in an acute viral season, up to half of childhood hospital admissions and even a quarter of adult hospital admissions are due to disorders with a heavy genetic component or complications thereof. Excuse me. So for the next 45 minutes or so, I'm going to talk about the biochemical, the metabolic disorders, inborn errors of metabolism. And you can think of the cell sort of simplistically as this big bag of enzymes. Enzymes are specialized proteins. They carry out one chemical reaction very efficiently. And for that to mean anything, the enzymes have to work in sequence. They go from enzyme 1 to 2 to 3 to 4 to 5, and sometimes many reactions. And you start with, excuse me, you start with one chemical and you work your way down to the final product. And an inborn error of metabolism occurs when there's a genetic defect that keeps that enzyme from working properly. And now you have a problem. You've got a block in that pipeline from enzyme 1 down to enzyme 5. And it can have two consequences. You can think of it as a pipe in your bathroom. So if you have a block in the pipe, you can have a problem with what's supposed to come out. You turn the faucet on, and there's no water to your sink. So you can think about that as being, say, glucose, sugar in the body. You have to have sugar, your body makes it. If it can't, you have a problem. But you can also have a problem with what backs up behind the pipe. In the case of the bathroom, that water is now going down into the basement and instead of the sink, and of course that's not good. Um, but in inborn errors of metabolism, you have these chemicals that are backing up that at smaller concentrations are perfectly normal, but as they build up, they can become toxic. And either the absence of what's coming out of the pathway or the backup of what's behind the block in the pathway can lead to symptoms. Our problem in this group of disorders is that while we've done a very good job of figuring out how to diagnose them over the years, therapy has been difficult. It's mostly been dietary manipulations. If you can't tolerate something, we take it out of your diet and try to keep you under control because of that. And there are some drugs, but it's been a slow process. Now, why is that? Well, it's because of the drug development paradigm. This is a sort of a classic view of drug development. You think about all these compounds being tossed in the top of a funnel, and you wait for one to come out of the bottom, and that's the one that works. And in that process, you go through a whole bunch of preclinical testing, meaning laboratory work, and then you build up from small study stage 1 to a little bit larger study stage 2 to the final study stage 3. And that whole process takes a long time, usually somewhere between 10 and 20 years. It's undirected. You start with 100,000 chemicals and you find one that works. It's inefficient. You go from 100,000 to one, and it's expensive because you have to test all those compounds to find the one. Now, the benefit that we have, especially in the last 10 or 20 years, is that we've come to understand more and more about the the effects of these inborn errors on the body, and we know what causes them. We know the gene that's affected. We know the enzyme that's not working, and we know the chemicals that are either missing or in excess. Um, excuse me. And so by knowing that, we have an opportunity to short circuit that. What do I mean by that? Well, here's another way of looking at that and that process with some additional emphasis on the preclinical testing, which can take anywhere from basic research up to the phase 1 trial. A lot of years. Some of us have been working on the diseases we study for decades. But what that means is, with additional technology available to us, we are able to short circuit going from basic research to through clinical trials a lot faster, which gets us to an approval for a medication. Excuse me. The reason for that is that we don't have to be so undirected out here on the starting point. We don't need to look at 100,000 drugs. We can do a lot of computer work. We can do a lot of cellular work. We can do a lot of clinical models and get down to really a good clinical candidate by being intelligent about what we're doing instead of trying to do it by brute force. So what that means is that over the last couple of decades, the proportion of drugs that have been approved by the FDA has really been dominated by the orphan drugs. This goes all the way back to the start of the Orphan Products Act, and what you can see is that most recently, for example, last year, half the drugs that were approved by the FDA were for rare diseases. This is a remarkable turn of events, and really. Gives us the impetus to look at the process and say, how can we make it work best for us in rare diseases? What's the right way? What's the right path forward to us? And so I come to my reliance on an old childhood tale, Alice in Wonderland. And you all know that Alice followed the white rabbit down a rabbit hole and saw all these things that she couldn't see from a standard viewpoint. And that's kind of how things were before the Human Genome Project. We didn't understand a lot of pathophysiology. We didn't know a lot about the genetics of these diseases. And so we just kept trying to look closer and closer at things and try to figure out what was going on. That culminated in the Human Genome Project. Now we know every gene, and we can use that to identify the genetic defects that are out there. But now, what does that do for us? Well, that allows us to turn our view outward and look more broadly at the big picture and understand how we can go from the chemical at the heart of the problem to the treatment of what it does to patients. And I like to think of this um, as the difference between looking through a microscope and looking through a telescope. This is a very interesting website. If you haven't looked at it, take a look at it. It's called Powers of 10. And what it shows is what increasing your power on a microscope or on a telescope does for you in visual terms. Now, I'm told this takes a long time to change on our for the due to the size of these images. So they may not all show up for you, but some of them will, and we'll talk around it. So what I'm going to do first is I'm going to go to the pre-genome era, and we're going to look through a microscope, and we're going to the scientists from about the discovery of DNA on through the completion of the Human Genome Project kept thinking if we could only go smaller, we would understand everything about a cell, everything about proteins, everything about DNA, and we would be able to fix it and know what was going on. So if we focus in on this gentleman who's taking a nice nap, and we look at about a meter, a 3 foot square, and now we start zooming in on by a power of 10 with every image. So first you go to seeing the skin, and you won't see the next one because it's just a close up of the skin, and this one might show up for you. It's yet a closer view of the skin, but now you start seeing the structures within the skin. This is instead of being a meter, it's a millimeter. It's a 1/1000th of a meter. If we scooch through the next few slides, I hope you now see that we're going in even further. That little square shows you what the next image is going to be. That's it. Now we're starting to see cells, individual cells, and the extracellular coating that protects the skin. Now you can see the cells reaching out and connecting to each other, as well as the proteins, the fibers that help define the structure of the skin. We're now down to a micron, 1/millionth of a meter. So we're getting pretty small. If we go down another power of 10, we actually start seeing DNA molecules. And so we've entered the cell. We're now looking at the DNA that keeps our genetic information. We go in another tenfold, and we've actually lost the ability to see the superstructure. We're now seeing the atoms that make up the structures. So in this case, the atoms that make up the DNA. And as we zoom in further, and I'm going to click through a couple of these to get to the last couple. What you now actually start seeing are the subatomic particles that make up those atoms. And that's about as close as we can get with our technology today. And so now let's zoom back up and start going the other direction. So here's our family having their picnic again. If we zoom up tenfold, we're now, instead of 1 meter away from them, we're 10 meters away from them. You can see some of the grass around them. You can see their size, and now each of those squares is gonna show you the we're zooming back. Okay, so you see that square in the middle there. The little blanket's now lost, but you can see the square. And now you can see the bay and the boats on the other side, and the cars on the freeway that they took there. And as we zoom out, here we're now 1,000 meters, so 3,000 feet, not quite a mile. Zoom out again, we now start seeing what looks like a map. All right, we're a lot further out. This is 10,000 meters. And I'm going to skip through a couple of these because I want to get to now 10 million meters away from that blanket. We now see the whole Earth as a ball floating in space. As you zoom further out from that, the Earth becomes a marble. I'm going to try to wait for a couple of seconds here, and I hope that shows up for you. It goes from being a marble to being a dot. It goes from being one dot to one dot in the solar system. Here, 100,000 million meters away, you see the red dot on the second line from the left is Earth, and we see the orbits of the other planets. We go one more step out, and now we're seeing the sun as a dot, or maybe a small bead, I guess. And I'm gonna zoom out a couple of more, and you start getting not just all of our solar system, but all of the surrounding stars. Since you're not going to see most of that anyway, I'll stop right here. And as you you go from meters to light years, so we're now 100,000 light years away. You see a galaxy, and what that does for you is that allows you the ability to integrate information at a level that lets you now try to identify what's the global picture here, or the universal picture, if you want to go with my last image. Let's go back to that human genome and see what this means. So now that we know every gene in your body, what can we do with that? Well, we could theoretically sequence every baby born, and we could use that to tell us information about what that baby's risks are. Now, we could tell you about those baby's risks across his or her lifespan, but you probably don't want that. You really only want the information that is necessary to take care of that baby and make sure that the baby stays healthy. Sort of newborn screening at a super level. But that information now there is available across that individual's lifetime. Most of you, when you take your child to the pediatrician or the PCP for a 1-year checkup, they'll check a hemoglobin, make sure the baby's not anemic. Well, why not check the genes that might be of interest in the next year to 2 or 3 years of life at that same time? When the baby gets ready to go to school, there is a series of tests that have to be done. Why not look at the genetic information and see what happens, what the risks are in the next few years of life? And this can go all the way up to adult onset, late onset disease, perhaps even genes that have some benefit for longevity and allow you to program a lifestyle that will let you live to the maximum amount of time. The bottom line is that in the context of genetic disease, most people who have a genetic disease, it takes a long time to identify it, years. And this approach, that's often called the diagnostic odyssey in the field. Families who are going from one doc to another, or one center to another, trying to find out what's wrong with themselves or with their children. And this approach breaks the paradigm. It can allow a rapid diagnosis based on clinical symptoms at any time. You've developed some symptoms. We can just go ahead, program that back into the computer, and see what your genome has to tell us. Now, to bring this a little closer to reality, it's not just your genome that influences your health. Your body is not just made up of DNA. DNA is made into RNA and is made into protein. That's something called the central dogma, and it's been recognized for probably almost 100 years now, 75. And because proteins can be enzymes, and enzymes make chemicals, or transition chemicals, the health of your body can look at all of those parameters and identify things that may be out of whack that could be causing you clinical problems. How do we do that? Well, we talked about sequencing the human genome. That's a technology, or leads to a field of information analysis. It's called genomics. Well, in the same way you can analyze the genome, you can analyze all those other molecules that I talked to, and they're all called omics. So we have proteomics, we have genomics, we have the RNA that's made from the genome is called a transcript. So we have transcriptomics. Your chemical pattern is your metabolome. So we have metabolomics. And we have technologies now that can look at all of these molecules and help us know whether or not they are in balance or out of balance, and maybe playing a role in your disease. You can make up an omics word for almost anything we do in medicine. So people talk about ionomics and lipidomics and phenomics. It gets a little silly after a while, but the take-home point is that with modern technology, we're no longer trying to look small. We're trying to look big, and we're trying to use the images that we see from afar to improve diagnosis, to understand the pathophysiology, the causes of disease, understand disease variability, identify things that allow us to know whether you're sick, and if you're sick, whether you're getting better, because that allows us to monitor therapies. So this is this is my new era. This is where we're no longer looking down the rabbit hole. We've come back up, and we're looking at novel ways to identify disease and follow therapy. And it comes down to be a numbers game. There's just a ton of information at each of these steps. There are 3 billion DNA bases in your genome. So there's probably the most information at that level. But it's hardest to know what it means. Sequencing the RNA, the transcripts from those genes, is more difficult because every tissue, every cell in your body has a different pattern of transcription. But it can identify things that you can't tell based on necessarily on the genomic sequence. Protein identification at this point takes is a different level of technology. We cannot see as many proteins in a single sample as we can RNA transcripts or DNA information. But it's a little bit closer to the disease. So if you can find a protein that's abnormal or not working properly, it gives you information that is in the context of these omics analyses, allows you to go up or down a little bit. And then for areas of metabolism, metabolomics is increasingly important. It's the most limited in scope, but it reveals patterns that are useful beyond looking at a single diagnostic chemical, diagnostic metabolite. So what does this all mean? How do we turn this into the therapies that we need, not and in those instances where we still don't have a diagnosis, the diagnoses that we still need to make. Well, we need to be able to bridge the gap, excuse me, between identifying a problem and being able to fix it. I don't know if any of you are from Pittsburgh and watching this, but if you are, you might recognize the bridge to nowhere. This is a bridge that was built downtown, and they started building it, and then they suddenly realized that there were things on the other side that they didn't have the authority to tear down, and they didn't have any place to bring this bridge back down. So it stood like this for years and years. And it's still there. I'll show you what it looks like today in a little bit. But we can't just stop by understanding some of the information. We have to turn it into a therapy if we're going to make this excuse me. You can't see me, but I'm drinking water here. All righty. We want to turn this into therapy. So how do we do that? Well, there are lots of places where you can intervene for therapy in metabolic disorders and biochemical disorders. This is true for the general disorders as well. But I'm going to be talking specifically about the inborn errors of metabolism because it's where most of my work in the laboratory is. And if you think about an enzyme reaction, it's right here in the middle of this image. As I said, an enzyme is a specialized protein that takes one chemical, it's called the substrate, and it turns it into another chemical called the product. If you break that reaction, if you have a mutation in a gene that causes that enzyme not to work or not to be made, there are a bunch of things that you can do to try to get around it. So if the substrate, if the starting chemical is toxic, you can try to decrease the amount of that's coming into the body. That's that diet that we talked about. You can also try to get rid of it through an alternative pathway, another way of getting it out. So you can think about that as dialysis. When you have kidney failure, you get the toxins out of your body by dialysis. But there are alternative ways of doing that with other enzymes, and you might be familiar with lysosomal storage diseases. We treat those with alternative enzymes, but although we don't do it at this level, we actually do it at the product level because we use it to chew up the product. And enzymes need vitamins to work. Those are called cofactors. So sometimes you can just give a whole lot of the extra cofactor, and that makes it work. Or you can replace the enzyme. Well, how can you do that? Well, that's what a liver transplant is. We treat a lot of metabolic disorders by a liver transplant. But it's also gene therapy. Gene therapy has been a technique that the people have said is just around the corner for the last 25 years. It may finally just be around the corner, but it's still not there. And then enzyme replacement therapy, as I mentioned. So, and then there you can give molecules, chemicals that help the abnormal enzymes work better. Those are called chaperones, and so lots of ways to look at this pathway. And I'm going to give you some examples just from my own laboratory work where we're utilizing these different ways of treating disorders. So I work mostly on a couple of different groups of disorders. One is organic acidemias, and one of the organic acidemias that has had absolutely nothing to offer is something called combined DL2 hydroxyglutaric aciduria. These patients have a block in a protein that takes a molecule called citrate from inside the mitochondria, the powerhouses of the cell, to outside the mitochondria. And you think, well, what the heck Why would that be such a big deal? Well, it is. It turns out most of these kids have a very severe clinical picture with low tone, difficulty breathing, poor development, seizures. Many of them die within the first few months, the first few years of life. Um, and by using an omics approach, you can see a large number of abnormalities in these individuals, and including this chemical that builds up, and one of the things that we can do, knowing that, is that we can show, for example, that if you there was some thought that if this was a difficulty in getting citrate out of the mitochondria, maybe if we give the cell some citrate, it could get better, because now it had citrate in the rest of the cell. Well, that turns out to be a bad idea, because what it does is it makes the patients worse, and you can see that here by looking at the 2-hydroxy glutaric acid, is higher in this patient treated with citrate than when the patient wasn't treated with citrate. So what's the problem here? Why does citrate give you this buildup? Well, it turns out, and I apologize, this is chemistry. So you got and all I'm going to tell you is that citrate is turned into another chemical called 2-ketoglutarate, which is a normal chemical in the mitochondria that helps make energy. But if it's present in too high a concentration, two other enzymes in the mitochondria are able to now start working with it, and they turn it into the L2-hydroxyglutaric and the D2-hydroxyglutaric. And so that's where this comes from. And it turns out that these are toxic compounds. And in addition, however, if the citrate can't get out of the mitochondria, turns out you need citrate to make all of the lipids in your body, or at least as a starting point to make lipids in your body. So if you can't make lipids, your body just really can't work very well. These are the lipids, are the chemicals that make up the boundaries of the cell, the membranes of the cell, and do a lot of the cell signaling. And so the question is it this problem, the high 2-hydroxyglutaric in the cell, or is it this problem, the lack of these lipids that cause the problem here? So we developed a treatment that could reduce the 2-ketoglutarate in the cells, and therefore lower the 2-hydroxyglutarate. And when we tested cells, we could see that it improved them. This is a test that measures the ability of a cell to make energy, and it turns out that these cells don't make energy very well. In this graph, the lower the line, the worse off the cell is. And so down here, the normal would be way up here somewhere. These cells are not making energy very well. But if we give them this drug that we developed, that at higher and higher concentrations, the energy production by the cell improves, and then the ability of the cells to carry out another important function in the mitochondria, breakdown of fat for energy, increases. Here you can see that these are two different cell lines from patients who have 2 combined DL2-hydroxyglutaric aciduria, and their ability to break down fats for fuel is decreased compared to this control cell line. And if we treat them with the phenylbutyrate, it increases in both of them. Is it working the way we think it is? Yeah, it turns out it is. We can treat. We can do one of these omics approaches. Now we can look at all of these molecules all at the same time, and If we do that, let me just go to the end here. What you can see is that if we treat that 2-ketoglutarate, or alpha ketoglutarate is another name for it. If we treat with our drug, it decreases by almost half. And the 2-hydroxyglutarate in the cell decreases by about 20%. Is that enough to make the disease better? Well, we don't know, and we're now getting ready to try a clinical trial with this. We've treated a couple of patients, actually know about 4 patients that have been treated worldwide, and we're still trying to decide whether or not it makes a difference. It may well be that we need to treat with this to keep the energy in the mitochondria working, but then give back some citrate because we're still not able to make the citric acid and the citrate and the lipids in the rest of the cell for the body. So this is an example of using metabolomics to identify a defect and now follow the chemicals that are important in the outcome of that therapy, and we'll look forward to seeing how that goes. I'm going to switch gears and I'm going to look at one of those disorders of fat breakdown for energy. They're called disorders of fatty acid oxidation. And one of them has a mouthful of a name, very long chain acyl-CoA dehydrogenase deficiency. It's just an enzyme that breaks down fat. And we use the abbreviation VLCAD to keep from getting tongue-tied. Our metabolomic studies were able to show that individuals with VLCAD deficiency ended up with not only the primary problem, which is right here, a defect in this cycle here. All of these chemicals appear to be reduced. But as well as not being able to use the fat for fuel. So we designed a fuel that these patients could use that would also help restore the balance in that chemical cycle, the TCA cycle, and patients got a lot better. What you can see in this diagram is every little symbol here, circle or square or diamond, was represented an event, either muscle breakdown, a problem in these disorders, that's called rhabdomyolysis, low blood sugar, also a problem in these disorders, and heart failure, called cardiomyopathy. And if they were hospitalized, they got one of these colors, either a hospitalization, an emergency intervention at home, or an emergency room visit. And then we started them and we watched them for a couple of years, or we got information on them for their previous 2 years, and then switched them over to triheptanoin. And I think you can appreciate that the number of dots or symbols over on this side of the graph in the light blue is way less than the symbol over here, meaning that these patients were having less events and they were being hospitalized less. Just to show this to you another way, what you can see is that patients who were on triheptanoin dropped their hospitalizations by 85% if they had were previously in a study, and then I'm sorry, that by 3/4 if they were previously in a study, and then dropped by 90% if they were naive to if they came in afterwards after the study that we started. And this is the hospitalization rate, and this is how long they were in the hospital. So they both had fewer hospitalizations and they didn't last as long. Another example of looking at the metabolomics to identify a defect that would not have been obvious with any other modality, and allowing us to design a drug to help these individuals. Well, remember I told you that genes make RNA make protein. So if the problem with VLCAD is a lack of VLCAD protein, can we give back protein? Well, it turns out the answer is no. You can't give a cell a protein and have it take up enough to get it in the mitochondria to make a difference. How about if we tricked it? How about if we gave it RNA and get that inside the cell? You can do that pretty easily by packaging the RNA in something called a lipid nanoparticle. And then you can give that to the cells, and you can see if they can now make the protein, which has all of the necessary signaling on it to get it into the mitochondria. And does that work? Well, so we have a mouse model of VLCAD deficiency. And if you look up here, you can see that in normal mice, this black band is a technology called a Western blot that lets you visualize the VLCAD, and it's present in the normal mice, and it's not present in the VLCAD knockout mice, and it's not present if we give them a shot of saline. That's not too surprising. This is just another protein that we know should be there, and it is in everybody. How about if we give them RNA? Well, the answer is if we give them RNA, you can see these are 4 different animals, and each of them got where by infusing them with a lipid nanoparticle, we were able to make enough RNA to be able to see it in their liver. If we did that, we looked at with we gave them saline, nothing happened, and this just shows the control animals as well. So it looks like this might be a therapy for muscle. Will it fix the heart? Well, it turns out the answer is no, because it doesn't get in oh, this is the wrong image. I'm sorry. Never mind. We'll just stay up here. Doesn't get in the heart very well. And I don't have that one showing here. So what could we do to make be able to get it into every tissue? Well, now we're starting to talk about gene therapy, because we have genes, we have ways of delivering genes to not just one tissue. That was delivery to the liver. It doesn't get into the muscle or the heart. But it does. The gene therapy vectors can get into every tissue, or it can be tissue specific depending on the vector. And what you can see here is I mentioned that maybe we're turning a corner. Well, as of mid 2022, there were 40 gene therapies in phase 2 clinical trials. Now, some of those have shut down since. But the predictions are that maybe by 2030 we'll have as many as 30 gene therapies approved, treating up to 50,000 patients. Is that a good thing? Well, yeah, it's a good thing. But the cost of gene therapy is horrendous. These are $1 million to $2 million drugs, and if you look here at this graph that shows the expenditure in prescription medicines from starting in 1978 and projected through 2026, what you can see is that it's gone from probably $10 billion and is expected to go up to $600 billion. Well, that's just non-sustainable. So we're going to have to come up with a new model. Is it worth it? Well, here's the results with our mouse with gene therapy. So if we take a normal mouse, you can exercise them; they just go forever. Turns out they can run around a football field if you let them. If you stick them in the fridge, they'll run around all night looking for cheese. They do just fine. They have none of the symptoms of our VLCAD mice, not surprisingly. They don't have rhabdomyolysis, this muscle breakdown, either at rest or with exercise. They don't accumulate one of the toxic molecules, lactic acid, and they don't have a problem with cardiomyopathy. We have two different versions of the VLCAD deficient mouse, and it turns out this one is more serious, and basically it can barely move against gravity. I mean, it walks around but has a hard time. It cannot tolerate the cold at all, and it has muscle breakdown at rest. It has muscle breakdown when it exercises. It has lactic acidosis when it exercises, and if you watch it over time, it develops cardiomyopathy. If we give that mouse our gene therapy, exercise is back to almost normal. Cold tolerance is not quite normal, but it's way better than it was. Resting rhabdo is almost completely back to normal. And it does a lot better with exercise. And it generates this much rhabdo because it's exercising more. The other animals just don't exercise. And we improve the cardiomyopathy by a lot. So the answer is yes, it's worth it. But how are we going to handle this as a system? Well, there's I like to talk about an ecosystem for gene therapy, and I'm not going to read this whole slide because we'll run out of time. But what it means is that we have to be able to scale the gene therapy to meet the needs of everybody who's got a rare disease, if in fact it can be cured by a gene therapy. That requires collaboration across all systems. It requires us to be able to identify these diseases before they individuals become sick enough that it doesn't help. So a screening method. We already have regulations in place that control this, but are they the right regulations? Well, it turns out if we use today's regulations to determine how gene therapy is going to get into patients, it'll take tens of thousands of years to get every disease treated. So that's not terribly useful. We need a different way to do it. We need to engage everybody who's involved in this: the physicians, the specialists, the primary care providers, patients, families, to make sure that we're addressing the needs that are there. And because this is very, very specialized technology, there's probably going to at least be some need for centralization. But we do want to be able to make sure that patients are staying as close as possible to home. So it is this entire system that needs us that leads us to where we need to be to give gene therapy. A perhaps even larger problem is how we get it out to everybody. If you've got good insurance, maybe it'll cover gene therapy. If you have less well insurance, maybe you got a big deductible. If you have no gene therapy, if you have no insurance, you're not going to be able to afford gene therapy. So we need to have innovative approaches to get this across the spectrum for not just our population in the United States, but for a world where there's not the economic bandwidth to do this currently. That's going to require engagement with those communities who lack resources, so allow us to democratize access to not only the therapies, but to high quality educational materials that allow everybody to understand what this is and know whether or not it's right for them. And in an age where people seem to think that facts are not necessarily facts, and science is not as trustworthy as it used to be, we've got to rebuild that trust in our healthcare system. I showed you the bridge to nowhere at the start of the talk. This is it now. This is the Fort Duquesne Bridge, and it now connects, goes across the river. They found a place for it to land, and it's now a major artery through Pittsburgh. That's what we need to be able to do. We need to be able to connect need with the ultimate outcome of developing drugs to treat rare diseases. This is not going to be old-fashioned pharmaceutical development. It requires an extensive understanding of pathophysiology and allowing us the insight to develop to identify targets and options for designing drugs that short circuit that process and let us get into market sooner. We'll almost certainly be using these omics techniques that I mentioned, because these new technologies will make screening, not only identifying diseases and monitoring diseases easier, but using the screening technologies to identify drugs at the cellular level that make a difference. We still need to figure out how to get our regulatory process in order, so that this is a manageable system. But if 20 years ago you had told me that we would have so many drugs in development for one particular rare disease, PKU, phenylketonuria, I would have said you were crazy. But look at this. We have gene therapy. We have small molecules. We have alternative substrates. We have recombinant enzymes, different enzymes that we can give the cell the way we've done for some other diseases. And while not all of these will make it to market, the simple fact that they're out there now is remarkable. Um, and really gives us a lot of hope that the next 10 years are going to be way better than the last 10 years. So with that, I'm gonna stop, and you see my lab and clinical research team and lovely clinical center here, our hospital and research center, and I'm gonna see if I can get out of here. Here we go. And quit sharing. And unfortunately, instead of seeing me, you see a big black screen. Um, I'm not sure whether you can ask questions or not, or if you can type questions in the chat. I'm going to stay here for about 30 seconds and see if anybody can. If not, I'll say goodbye and wish you a good day, and hope you're available for Rare Disease Day and to participate. Since I am not hearing anything, I am just going to. Oh, a question was assigned to me. Let's see. Let's see if I can see the question. Oh, it just says hello. Oh, what is, there's another question. I don't know how to get to that question. Can you just show me the whole question? I'm talking to my tech person.
Um, it says what is developed in diagnostics and meds for KUD?
KUD. So the problem with abbreviations is that they can mean a lot of things to a lot of people a lot of times. If you spell that out for me, or unmute and ask it. KUD. Let me see if I can figure out what that would be. Well, while you type that in, I'm going to answer the next question. Is that thoughts on drug repurposing? So absolutely, that funnel. Ketone utilization disorder. Okay, get back to you in a minute. Sorry about that. But repurposing drugs is actually quite a potentially useful technology. Or option, the drug that I talked about for my 2-hydroxyglutaric aciduria is a repurposed drug. I'm also repurposing triheptanoin to look at a couple of other disorders. So, if a drug's already approved, the pathway to approval for a second disease is a lot shorter. And so you can actually buy a panel of drug to test cells against existing drugs and use your screen and see if any of them work better. That's not going to work for everything else. But it's not going to work for everything. But if it works, you're good. You're good to go. Ketone utilization disorders. Um, I'll, 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 I'll beg off answering it very specifically, simply because it's there's a it's a long answer, and since there are 10,000 rare diseases, we could be here all day answering specifically. Ketone utilization disorders, when fatty acids are broken down to make energy, one of the things they make is ketones, and there are enzymes that allow you to do that properly and utilize them properly. And there are certainly ways of you can you could affect that in a cell. At this point, I don't know anybody who's doing that in a mouse model or getting ready to treat one of them, but there's no inherent reason why it couldn't be done. And this is the problem with that pathway that is from start to finish. It takes a long time to get there. And if you have to do it 10,000 times for 10,000 different diseases, it's difficult. Um, the best bet for you as a rare disease advocate is to find somebody who's working on that disease and work with them, help them with their research. You can do that by supplying money. That's always needed. But you can help them identify patients, get samples that are necessary to understand a disease. I talked a lot about using cells. Those come from patients. We do them for diagnostic purposes, but sometimes we just get them for a research purpose. And so overall, there's a lot that you can do to see what's going on, and to find those individuals. Go over to NORD, the National Organization of Rare Diseases, or go to something like Medline. You can access that on the internet, and just type in your disease and find the name of people who are working on it, and then email them. Nobody will view that as spam, I guarantee you. If you say I'm a patient with, or I have a relative with, the researchers will talk to you. They love to do that sort of thing. Um, I unfortunately have to do another one of these in 1 minute. So all those other questions, I'm going to have to sign out. How I'm treating rare disease? Well, I'll be in the office. This one was from home, by the way. I'll be in the office. We've got a number of celebrations going on for the day internally. We've got some lovely tchotchkes that our Center for Rare Disease Therapy passes out at the hospital. We're doing a research symposium where researchers for rare diseases in the hospital are demonstrating the work that they've done. We are getting all the buildings that would allow us to do it in the city, to turn their lights on to rare disease lights, which is some combination of rainbow colors, and so there's lots of things going on, but mostly it's making people aware. So I hope you find a way to make your Rare Disease Day profitable. And thanks for being on the webinar. For those of you who are viewing this afterwards, because it will go up on the Children's Hospital YouTube page. I look in advance for the coming year for new for things to do on Rare Disease Day. Bye bye all. I'm sorry I couldn't be visible to you.